Welcome everybody, it's Phil Russo here. This is the... let's start again.
I like that intro.
I like that intro, yeah. It's one of your best, I think.
We'll leave it at that then. Welcome everybody, this is Phil Russo speaking here, and I'm joined by Martin Keenan, who's wearing a special party hat, and Brett Mitchell, who's got his party tassels on. It's a special occasion tonight, chaps, isn't it? It is the 100th podcast of Infection Control Matters, so welcome everybody. It's going to be a bit of a light-hearted chat. But yes. First of all, I'm going to throw to Brett, who's got a special announcement to make.
Well, thanks, Phil. And, in light of our 100th episode, we've been working on something. And I'm really pleased to announce, insert drum roll here, Martin, when you edit this. Yeah. I'm pleased to announce that we have a website, infectioncontrolmatters.com. Now, you might be thinking that's not much excitement, but it is a bit of excitement, I think, because this website will enable you to do a few things that perhaps we never envisaged we'd have to do when we started off this podcast. So we
thought we would just be talking to ourselves, you see. That's the problem. Yeah. We've now got lots of downloads. So
now we've got lots of downloads, lots of people listening, and we thought we'd better make it a little bit easier for people. And the idea of the website is to do that. So you could go on to infectioncontrolmatters.com and you can subscribe. And when you subscribe there, you'll get an email alert, which you can click on when a new podcast is released. But probably better than that, there's the opportunity to look at all our different podcasts. And now that we have 100 in the bag, you can look at the different podcasts by different topic areas. So if you're interested in workforce-related podcasts or cleaning-related podcasts or contact precautions, etc., you can search by the topic and you could find all the related podcasts for that topic. So I think that's hopefully going to be helpful for people.
I think one thing is highlighted, interestingly, is the things that we haven't covered or not covered very much. So if you go looking for podcasts we've done on hand hygiene, which...
You won't find many.
No, there's one early on with Didier. And that's it. We haven't covered technique, motivation, auditing. We haven't covered really hand hygiene at all in any depth. We mentioned it. I mean, contact precautions and transmission-based precautions and, glove and no glove. But we haven't really had a really good chat about hand hygiene. So that you sort of see the gaps, don't you?
You do see the gaps. The other thing I noticed in our last podcast that went out, which is on C. difficile, and I was putting on that podcast onto the website, and I thought, what category is this going to go into? And I realised we didn't actually have a category on MROs or C. difficile. Now, we've covered MROs in some things like transmission-based precautions, but they've been more concentrated in discussions around transmission-based precautions rather than specific MROs. So there's another one that we haven't really done too much on, but I think we probably should. And there's plenty others. And there's plenty we have got lots on too.
So, Brad, is there anywhere that people can make suggestions for a podcast topic?
They can
on the website.
I think I've got the comment function open. If it hasn't, I will put it open so that you can make those suggestions. Actually, there is a contact us function on the website, and you can submit your feedback to us via that route. I don't think we've got the open comments available just because it's another thing to moderate, and we might review that. But you can easily send us through your comments via the website and ideas. There's some things we've really explored quite a bit. The workforce and professional related topics, we've actually done quite a few on those, and we've done a lot on contact and transmission-based precautions.
Pneumonia's being an interest, I think, is why we've done quite a few on pneumonia.
Yeah. I think in the context of pneumonia, I think we've done 5. So it's not as high as some of the others. Surgical site infections is a similar sort of number, for example. But yeah, I think air and aerosols we've done actually quite a few, and I think that's about 6 or 7.
Why were we here on that topic? I wonder.
I wonder why.
Because if you went back 5 years, we wouldn't have been talking about air at all.
No.
We're just a reflection of what's happening in society, really, aren't we?
Yeah, maybe.
Yeah, something like
or
that.
our preferences. So yeah. Look, I think please do send us through your ideas and topics. I think the other thing I was just reflecting on, Martin, the other day we were talking about. Oh, actually, before I get to that, the other interesting thing that I noticed when we worked out our 100 odd episodes is how many different speakers we've had on. And we're really grateful to our guests. We've had, I think, 110 last count guests on our podcast. That's guests. That excludes, of course, Martin, Phil, and myself. But 110. So that's pretty good for 100 podcasts, I think. And
well, funnily enough, I counted it up yesterday, and we're now at 117. 67 of which have been female and 50 have been male. So that's hopefully readdress the gender balance because we're all male.
Yeah,
so
we're all male. That's right. We are conscious of that. So that's got the guests on there. So we're really thankful to all the guests that we've had on. And I think at that time there's probably only been, I think I've had one person decline an invitation onto the podcast. I don't know how you two have gone with invitations sent out.
I've had, I think, 2. And generally due to pressure of work.
That's the reason. It's not for want of doing it.
Occasionally, I've got to run it past my organisation. I need a list of questions, and anybody who's listened to the podcast knows we never have a list of questions. we're really not that organised. We just let somebody start talking about their work and then bang in with the questions. Really, it's about as organised as today's is. Really.
Yeah, that's right.
No, I don't think I've had any rejections as such either. So we're very. We acknowledge the cooperation of everybody who have contacted. It's been fantastic. That's what makes it.
Yeah. And look, when we started this out, I didn't know what to think, but I didn't think we'd get our 100 podcasts, let alone the interest. So almost 60,000 downloads. How many countries have we got, Martin?
130 now. Well, quite a few of them are only one. So I was just thinking somebody's...
They heard it once and gave up.
Well, that's right. Somebody's gone called in from Aruba and gone, whoa, these guys are nuts. I'm not bothering with that one again.
And that wasn't you travelling around the world, was it, Martin?
No, it wasn't. No, it wasn't.
That's right. He's got a VPN and just downloads them from different countries to make it look good.
It's impressive, really, because, we speak... bad English, basically, because we talk very fast. And yet we've got people from 130 countries who have listened to at least some, and in some cases, quite a lot of our podcasts. So that's, considering we have that potential language barrier, I think pretty good.
So that's the big news. If you want to get involved, please get onto the infectioncontrolmatters.com website and you can subscribe there, and then you won't miss anything. And hopefully it'll be a bit easier for you to receive that email when a podcast is released. And it has a bit of a summary in the email, so you better just delete it if you're not interested, or listen to it if you might be interested in it.
Can we just think of some other topics we haven't covered then? Because with the exception of the live one from Assipsi last year, we haven't really done much about infection prevention outside hospitals, certainly in aged care, in nursing care homes around the world. So that would be something we ought to really think about, because there's certainly a move in the UK to move healthcare outside of acute hospitals. They're talking about virtual wards, that sort of thing. So that'll be quite interesting. And we've only had the one, I think, on whole genome sequencing, and that is really, a focused effort in one organisation. And I wouldn't mind exploring where that's going to take us in the future, because I've come from an era where you wait days to get a specimen result from the lab, or in the case of norovirus, when I started, 6 weeks till somebody stared at enough poo down the electron microscope to tell me I had an outbreak 6 weeks ago. So this is going to be a game changer, really, isn't it?
Yeah. Yeah, that's right. We probably only had a couple on whole genome sequence. So, that would be good. And I agree about aged care. We haven't really touched on that. Scopes, we haven't really done a lot on scopes, endoscopes, and various other types of scopes and risks related to those. We haven't really gone down the sterilisation route much either. Admittedly, that's probably a little bit trickier and to go down, but probably another area that we haven't looked much at.
I had something that aged care is, I mean, we're going to reflect what's hot and what's in the journals, where the grant money's going to, isn't it? Aren't we? So I can see a lot of effort being put into the aged care, and I think that's a really big area that we probably actually need to get a bit more into. I'd be really fascinated to, what we've learned over the past couple of years of what does the aged care facility of the future look like, because we still need to make sure that it's a home, because they're residents, not a healthcare facility as such. And so knowing what we do know with the recent pandemic, how would the new aged care facility look like? So there's a few topics that I thought would be curious to explore this year.
In fact, just touching on that even more, Phil, the design element, we've alluded to things like air, but we haven't really gone down some of the design elements of healthcare facilities to minimise infection risk that much, apart from the air side. We've gone probably explored that a bit, but lots of other things related to that we haven't touched on. What about you, Man?
Yeah. I was thinking surveillance, to be honest. We haven't really covered that in any great depth either, talking about surveillance methods. I mean, actually, the one we did a couple of weeks ago with Judith Tanner and Melissa Rochon is actually our third most popular podcast, and that was only out a couple of weeks ago, and that's had over 800 listens, and so people are interested in that aspect of actually detecting surgical site infection and actually what we can do about it. And there's certain aspects of that we never really go near. We haven't discussed it, with a surgeon, for example.
Yeah,
which would be a good thing to discuss.
Chuck Edmiston, I did have a chat to Chuck Edmiston about that.
That's been one of the most popular ones.
Not about surveillance, but I really liked the one with Melissa and Judith. It's probably is a reflection of my brain, but I like simple things, and I think that's a really simple activity that they've implemented and had good results. I think surveillance. I think the surveillance that we know today is going to be dramatically different in 3, 4, 5 years' time. And we need to think about smarter ways of doing surveillance. And I think in the Netherlands with Mikey van Meurik, etc., are already doing that, and we need to learn from them.
Yeah.
I mean, to actually how much we can automate surveillance to actually keep pointing us in the right direction, because it won't be as perfect as a properly organised point prevalence survey. But if you've got some automated surveillance kicking up in the background, which says, OK, this is somebody you ought to have a look at, that really might help. But it would depend on whether or not, of course, you've got a computer system that collects those data. Some of us use ICNet in the UK, but you've then got to buy the interface for all the other hospital systems that might have the information you need, and it starts to stack up. So then we're into economic arguments, and actually that's a topic we've not really covered. The cost effectiveness of healthcare associated infection and how you make a business case out so that when you're arguing with your finance director, I want to invest some money in this and it's going to take you this long to get the return on your investment. Sometimes we don't actually have much data to base that on, but that's a topic we haven't really covered in any great depth, really. Return on investment and how we argue for the resource we think we need.
Yeah, that's a good point. The other thing that sprung to mind, and it's just sprung back out of my mind.
Oh, yeah, it happens all the time.
I'll tell you what. That's, that was it. It was, we haven't, I saw something at ECMED, I think, coming up in a week or so, where they talked about, there's a session on upcoming research. So research that's basically in the pipeline. What have people got going on? And that would be really interesting to hear, because often we don't hear about research until the findings are out there. And by that stage, people go, I wish I'd known about that because I was thinking about that's something in my own organisation, or I wish I'd known about that because I could have joined or been part of that because I've got a real interest in that. And I'd be interested to see how that session goes at ECMED, and I wonder whether, from sporadic time to time, we should have a bit of a call out to people who are doing, it doesn't necessarily have to be research, but even quality improvement activities within their hospital that they think they might like to collaborate on with. And this might be an opportunity to go to hear what the people are doing in that space and see if there's others that have either done it or want to share their experience or be part of it.
Particularly if they've got a good implementation strategy for actually trying to put something in place. I'd be keen to have a chat about that, because that's another topic we haven't really covered in enormous depth. I mean, we briefly mentioned it with David Webber when we were talking about his integrated infection prevention team, but actually, where does implementation science come in and, because I've sat at conferences and I've learned a bit about implementation, but I'm not somebody who has a doctorate in it, that's for sure. And so maybe, the number of times I thought I've implemented something and it turns out 6 weeks later I haven't, because I've probably implemented it really badly. That I think would be an interesting topic to cover. You haven't gone near that one.
No, and the hot topic at the discussion at the moment is a Sudoku trial for the selective digestive decontamination. I think it was published in JAMA quite recently. Showed some interesting results in respect to reduced mortality, and there's a bit of discussion, lots of discussion about that at the moment. And one of the key other discussion points is, does that sort of thing pose a risk in terms of antimicrobial resistance? And it'd be probably interesting to get some people on from perhaps the Sudoku trial to talk about what they did and how they tried to explore that issue of antimicrobial resistance.
Yeah, it's a controversial issue, isn't it?
Yeah.
Do you want to elaborate a bit more on that, Brett, and what the controversy is?
Well, I think there's some discussion about the endpoint of mortality and whether it makes a significant difference or not. And that's a real methodological debate and statistical debate that's going on. I won't go into the ins and outs of that because that'll probably bore people to tears at the moment. But the other side is giving people this sort of cocktail of antimicrobials to reduce things like bloodstream infections and colonisation of pathogens, to subsequently reduce infection in ICU. Whether that has some inadvertent effects of causing or contributing to antimicrobial resistance. Mm-hmm. And that's one of the things that is being discussed actively in relation to that trial at the moment. So, anyway, that's...
That practice has been going on in the Netherlands for years, though, isn't it? It's taking non-systemically absorbed antibiotics plus a mouth paste, as I recall.
That's right.
To try and reduce oropharyngeal colonisation. And you would think you would start to see changes in the sensitivity of organisms in that area, and I'm not sure I've seen any reports that show that. But we're often scared of things we don't know about. Especially if they instinctively feel like, actually that's going to do damage. Like many people feel that you shouldn't be using disinfectants because we're going to increase antibiotic resistance, etc., etc. And I'm not sure the data has borne that up, but it's a natural fear that people might have because you don't want to make things worse. And
that's right.
I get that.
The other thing that I was sort of springing to mind in the lead up to this podcast was on a related topic to that, actually, and that is sort of that decontamination issue. We haven't really just gone into too much detail about any of our podcasts in terms of, clexidine bathing or decolonisation approaches to reduce the risk of subsequent bloodstream infections in various settings. I think Susan Huang's doing a lecture at the IPS conference in October.
October, yeah.
Yeah, so I think that's something we haven't really covered much either on the podcast.
Phil, what else is on your list?
One of the things I had on my list was what type of skill mix makes the best IPC team. And I thought of this because of the chat with David Weber and his large multidisciplinary team. But just interesting, there was an advertisement recently, for the manager of an IPC program at large hospital. And the person didn't necessarily need to have nursing qualifications.
That's common over here in the UK. That's common. Okay. Well, John Otter heads up the IPC team at Guy's and Thomas's, which is one of the biggest teaching hospitals. Mark Garvey at Birmingham is a clinical scientist. He heads up University Hospital Birmingham. Elaine Clapman-Green heads it up at Great Ormond Street, where she's actually the infection control doctor as well, and yet she's not a medic. Mm-hmm. So that's not uncommon, I don't think. And there's a number of people working in that area. So
I think that setup is quite unusual in Australia. I would suggest that most heads are nurses. They might have a medical lead as a co-lead of the program, but this was the first time I'd seen an ad. First time I'd seen an ad for a non-nurse.
That's a good thing, though, I think. Over here we have IPC teams who've got operating department practitioners, which I don't think is a role you have in Australia. Operating in the operating theatre now, you don't train to be a nurse and then go into theatre. You train as an operating department practitioner, where you do a degree in operating department practice. My daughter's one, and because you then can focus on that for 3 years. She does cardiac anaesthetics at the moment, and so we have teams with ODPs in them and also dental nurses in them. So they've gone from non-traditional backgrounds, apart from clinical sciences, etc. So that would be. I think that's good. Actually, it'd be interesting to see who applies. What sort of background they come from. Fascinating.
Yeah.
Thinking about the most listened to podcasts, what are some of the topics that have been more popular than others, would you say? Now we've got 100 under the bag.
Yeah, Air's right up there. I mean, the ones that series we did on Air, there's a couple of those in our top 10. But interestingly, just discussions with people. We had a chat, you and I, at IPS conference with Jean-Yves Maillard and Annette Jeans, just talking about her work in the film industry during COVID and also his work on biofilm. And that's right up there. I mean, the surgical site infection and the imaging, the simple practical one that Phil mentioned, that's right up there as well. So, yeah, and actually just a chat we had with John Otter about his glove or no glove one. Also interesting is Are We Experts one's right up there as well.
Oh, right. Do you know what I would find? If there are people out there who've got these sort of IPC roles in obscure areas, it'd be great to have a chat. The film industry was a fascinating one to hear about, and there's there'll be, I'm sure, plenty of others out there. So it'd be interesting to hear just how diverse we are.
Yeah. If you know somebody working in a slightly left field area, then get in touch with us via the new website, and we'll have you on to have a chat, because because actually people working in those areas, Annette was very good about saying about how she would go to someone and say, tell me what you need to do, and then I will help make that safer for you during this period, rather than us turning up and saying, that's what you need to do. It's all about actually tell me what you have to do, and then I will make it easier for you. And actually, I thought that was a lesson learned for working in a hospital, to be honest.
If there's an IPC consultant for the Ashes series in the Northern Summer, I'd be very happy to chat to them and see how they do it.
Actually, and that has gone into sports teams in the past. She's been contracted to sports teams to go and stop them getting things like norovirus and talk to them about not picking up communicable diseases from their kids and, colds and flu from their kids when they're starting nursery and that sort of stuff. So, people have been contracted in those sort of areas.
I've got a question. Just going back to the IPC paradigms of contact and droplet airborne precautions that we did do that series. Do you think that had much impact? Do we need to take it anywhere else, or take it further, or explore it further? Because it would be a shame to leave it sort of sitting there, not.
Yeah, I
guess.
I
think all we can do is air the debate, isn't it? And hope that when people write their next set of national guidelines, then they would start to consider that. And I certainly have the feeling that CDC are going to be looking at transmission-based precautions and change things about.
Yes, I saw a meeting note from the CDC for the review of the transmission-based precautions guideline. I can't remember the exact term, but the one that's from 2009. And there were some notes that came out the other day about what they've been discussing. And you can actually see them on the CDC website and see some of the discussion points. There's certainly a trend to move to respiratory-based precautions as a term. That looks like that's got some traction at the moment in discussions, reading between
I like
the
the
lines
transparency
there.
of that. That's very nice. It's nice that at a national level they're being transparent with what they're discussing. I like that.
Yeah. The other interesting thing was there was discussion about making sure they need to understand the sort of implementation aspects. So how is something practical and implementable and tolerated and acceptable and all those types of things as well. So I think that's refreshing to see as well. And I think that whilst the grade approach to developing guidelines has got some advantages, that's where some of the challenges I think have laid. We're trying to come up with infection control guidelines where there hasn't been that, the RCTs because they can't do them or not ethical to do them. And so I think that's interesting that's coming up, I think. Yeah.
Do you know the frustration is, though, Brett, that you do an RCT and nothing changes. So you did your one on Corti. And what's changed?
Yeah, look, I think they do say that things take about 7 years on average to get implemented once they're published if they're worth their weight. But there have been some changes to national guidelines in Australia. So there is a little update to that to consider the use of antiseptics such as cloxine prior to catheter insertion. So I think those things can happen. But really that goes back to the need for us. And I've been saying this for years, that we need to have a much more global approach to the evidence base around IPC. We're trying to all individually develop guidelines in local countries. And context is important, right? So context I'm not talking about here. I'm just talking about doing the hard work of the methodological review of evidence and coming up with this quality of evidence that might underpin any piece of thing that we do. Now, that's not about whether the recommendation that comes in individual countries and states or jurisdictions, clearly that's local context and locally based, and I would encourage that. But, otherwise what we end up with is all these countries coming up with guidelines around the world that they try and find funding for every 3 years. Then the funding's not there when they need to update them. And, we're seeing it with EPIC guidelines in the UK, for example. I don't know when the last time they were updated. So CDC guidelines, from 2009, 2013, HICPAC guidelines that are 10 years ago.
More than that in many cases. Yeah. I mean, actually, your paper, yours and Phil's paper, looking at the strength of evidence in the guidelines was an eye-opener for me, really. And that didn't include some guidelines that were actually current, that were before the time you looked. Yeah.
So I think, we could easily try and do this at a much more global level, and have it more frequent so that the evidence, as it's not necessarily emerging, that would be ideal. But even if it was every 6 or 12 months, some of these things were updated, it would make it easier for local governments or health organisations, trusts, boards, whatever, to look at that and go, this is what we need to do now. And still be able to base that locally. So
I think what you're saying, Brett, is really that the implementation is harder than the actual study, the actual research that identified the intervention that needs to be implemented. I think that's we come from a country with 6 states and 2 territories, and they never agree. So it's really hard to get that uniformity of implementation on policy and practice. It's a hard road, and maybe that's something that we need to explore ourselves, and that could be the qualitative aspect, that implementation science, which is becoming increasingly important in infection prevention research, I think.
Look, I've been saying this for years, but, we try and look at this black and white approach to things, and it's never black and white. I mean, I've talked about shades of grey, and I think Elaine's talked about that in the past in one of her podcasts as well, but it's not that. And so that doesn't mean we shouldn't have evidence-based guidelines or the evidence summarized and evidence summaries. But I think we need to be able to have the ability to tailor what that means locally for individual epidemiology, for individual context, for different cultures and different organizations, different resources that people have got. And not necessarily have a blanket approach, but still be able to provide people what is the latest evidence, and you can interpret that to your needs. I think that's the key. And both of those things are missing right now, in my mind, across the world.
Part of the problem is if you get the killer new study that says this makes a big difference, and your national infection control manual or your national guidelines says we haven't got the evidence, and that's not going to be updated for 5 years, it becomes quite challenging for people sometimes to say, okay, we're going to adopt this new practice, even though it isn't the national guideline, especially if somebody's coming up and like to say, are you following the national guideline? Yeah. Well, the national guideline may be out of date. So you've got to be pretty ballsy, really, to be able to stand there and say, we're not going to follow that because we're convinced by this new evidence and we can't afford to wait. And there was a paper that showed the effect of waiting to implement something, for something like, I think it was something like CLABSI, and a 9-month delay in implementing the correct bundle because it got stuck in the hospital system cost them hundreds of thousands of dollars in extra infections, rather than saying, this is really what we need to do. We all know we need to do this. We're going to start this now. And I think that was an interesting aspect as well.
Yeah.
Listen, boys, we rabbited on, do you think?
We have. I think we probably talked enough about not much.
Yeah. Well, that was just you, Brett.
Yeah,
Yeah, that's right. Taking up enough airtime.
Yeah. I mean, do you want to mention the new website, by the way? I don't think you've
have we got one?
Yeah.
Look, I think the other thing with that is the reason for the website is Twitter algorithms are getting a little bit mixed, and we know this sort of podcast goes out in different forums, but we're trying to diversify that a little bit as well. So trying and cater for everyone's tastes.
So just the summary that this is the 100th episode. What was the time frame? Did we mention the time frame? 100 episodes in...
Yeah, what? We did this 2021, didn't we?
When was the first one?
We started. Hang on,
you can tell how well organised we are.
Yeah. 29th of March 2021 was our first day. And we had
our first podcast was...
Yeah. 8 people was downloaded on that day.
Just after I turned 32. That's good. So,
and I think our first podcast, just to put it out there, was on COVID myths after our introduction.
Yeah, that's right. Yeah, COVID myths was our first true one, and that came out about a week later, I think.
Yeah.
Dear. Do we dare listen to that one again?
Oh, that was actually a good one, and I think
that was a good one. That's still one of our most popular ones. Yeah,
and debunked a lot of myths at the time that were around.
Yeah. It's still our fourth most popular. And it's still our fourth most popular, and it stands up very, very well. In fact, it's definitely telling me I was wrong. And okay, fair enough. But that's been one of our most popular. Yeah.
Well, we're all wrong, and we've got to admit to being
we're all wrong.
Because
I don't mind being wrong.
It's the only way to get better.
I'd rather be wrong and learn.
Yeah,
that's for sure. Yeah.
Now, the other thing, Phil, you made a good point about how long we've been going for. But, moving forward, last year we were trying to pump these things out almost every week. And we're not going to put a time frame on how often we're going to continue to do this, but we were sort of aiming for fortnightly. And there might be times where that's occasionally less. There might be times where that's more frequent, particularly when Martin's jet-setting the world and
going to conferences.
Going to conferenses everywhere.
Pulling people up in the corridors.
Yeah. So we might have some more frequent ones during certain periods of time. But it's, we sort of do this when we can, and we're also at the whim of all our guests that give up their time to be on the show too. Did I just call it a show? Yeah. I think I just called it a show.
Yeah, well, no, I don't know. It's exposition. I don't know. We have a period where we don't do very much, during your summer, Christmas time, that sort of stuff. But, if topics came along and we had the time, we would fit them in. But, yeah, you're right. We don't want to commit to a particular time frame. But it'll be pretty much 2 weekly at most, I would think. Depends on how many we've got in the can, as it were.
If people go to the website and subscribe, they'll be told straight away when the new one's out. Is that correct? Yeah.
Exactly.
They won't miss a thing.
Because our only comms method really has been Twitter and organisations like ASIPSI and IPS kindly putting it in their newsletters to let people know, which explains why the majority of our listeners, the biggest group are from Australia and the UK. So we don't actively publicise really, apart from Twitter.
A little bit of suspicion about the utility of Twitter moving forward. So this is a much better option.
It's getting a little bit worse. All right. Well, as always, lovely chatting, Phil and Martin.
Yep. Yeah. You've given me plenty of challenges with editing, so for that I thank you.
Oh, yes. Look, and thanks, Martin, for your editing abilities. We do. I have been doing a bit of typing in this one just to throw it in the mix for you.
Yeah, I like that. Yeah.
Edit those things out. Look, thanks, Phil. Thanks, Martin. And thanks, everyone, for continuing to support and listen to us. And we are, as I say, we're generally interested in the feedback. So please, in all seriousness, do shout us some comments through via the website. We'd love to know what you like and don't like and what you want to hear. All right, that's it from us in this latest episode of Infection Control Matters. And we'll speak to you again soon. And we'll do another one of these when we get to 200.